Next up on the agenda is the wonderful Professor Michael Back. He's the Director of Radiation Oncology at North Shore and Genesis and various other places. And unlike many other radiation oncologists, he's really passionate about research and is the Director of the Brain Cancer Imaging Laboratory. Please, and he's very involved with the Brain Cancer Group as well. Please make Michael very welcome.
Thanks, Liz, and thanks for the invitation. Thank you for all being here today, and hopefully we'll pitch this in a way that, as Jacob mentioned, there's a lot of things that individualise, and also a lot of things are hopeful in a situation where historically we've had problems. So we're making breakthroughs along the way. They're small steps, but we're learning a lot more about what happens within a tumour, how it behaves, and how we can deal with it, not only up front, but also if something is returning. So there's relevance for people who are coming here who are facing this for the first time, or people who have already had some treatment and looking for options in the future. So yeah, the role of the radiation oncologist, I thought I'd flick it around a little bit and talk about what is important to know, where it's changed, and where should you perhaps feel a bit more confident going into the future. So radiation therapy is the use of high-energy X-rays to treat cancer. They're the same as you get a chest X-ray, except ours are more powerful. And they're ionising radiation causing damage to cells. The features which we have is that they're very targeted and precise. And as Jacob mentioned, they're really individualised. All our treatments need to be individualised. And they can damage tumour cells, but the most important thing is we aim to spare the good cells within that. So we'd like to give a lot more dose to the brain, but we can't do that without potentially injuring normal parts of the brain. So it's our challenge to work out exactly where tumour is and steer the dose and steer the treatments away from those good areas. A quick bit of dogma, or I guess my 3 quick tips to patients who are going through this journey, and I think people in the audience probably heard some of them before. One is that how you walk into a radiotherapy program is generally how you should tolerate it. So if Jacob can get you through your operation, walking, talking, eating, thinking, then we should be able to maintain that reasonably well. The side effects are really dependent upon the site. So there's no specific global side effect because different areas of the brain look after different parts of your function. And it generally comes down to one big factor for a lot of our side effects in radiotherapy, and that's swelling. And it's actually not the swelling from radiotherapy on normal brain, it's the way the tumour breaks down and responds to radiotherapy with production of inflammation. The third thing is really mobility is the key. So I say to my patients, if you're not working, you're walking. So during the course of radiotherapy, you've got to keep active. And there's no cotton wool in our departments. So the best way to get over the tiredness effects from a lot of treatments is to actually keep active. Now sometimes you can't be active, so you've got to modify those things, or if you've got something which is impacting on your mobility, then we need to work hard to try to reverse that or improve that with physical therapies, etc. So a radiotherapy pathway, you really go through from a point of decision making and then going through to follow-up care. Specifically when you come through to a radiation oncology department and we've gone through decision making and everything has to be individualised because everyone else's tumour is different to yours, it comes down to design of the treatment, planning, and then the treatment delivery. But importantly, also sort of follow-up care. Now, there's 2 aspects which I really concentrate on. One is target design and the other one is follow-up. We have a lot of historical emphasis on machines, but the machines, especially across New South Wales Health, are really good, high quality, and you're getting equivalent care. So the radiotherapy department is not down to machines, and in brain tumours it's not down to the actual machine you're on, but how that treatment is designed and how you're managed afterwards and how your response to treatment is interpreted. So target design or target volume design is one of the most important aspects. And we need to get as much information as possible from what Jacob's done beforehand through to the imaging that's performed. If we've got uncertainties about imaging, we'll repeat imaging. So you and the MRI machine eventually can become good buddies because you've got to go into that tunnel a fair number of times for us to get good information. And the preparation in this part is important. In patients with high-grade or aggressive brain tumours, we like to get started on the treatment fairly quickly, but we need to be able to get as enough information as possible and make sure we've got that ready for decision-making. So here on the image, we've got the MRIs, which Jacob has shown, but this is an example of a PET scan. So the MRI is looking at structure in the brain, and the PET scan is looking at metabolism. Now, in most situations, PET scans aren't required, but in certain situations, a PET scan can give a little bit more detail on the nature of the tumours, and we'll implement those as required. We're fortunate now to be doing a large study across Australia, which is looking at the design of treatment with a certain type of PET scan, and hopefully that will flow on to greater access in the future. The next thing is really important, trying to work out where this tumour is, but also where it's going. So historically we thought of tumours as lumps growing like that, but now we know there's an association of these tumours with the white matter tracts and how they involve and extend through the brain. So I like to think of the brain as a multiple number of roads or highways, and you've got to try to work out which highway this tumour is on because you want to know where the destination point is. So we use the imaging, and you have to individualise this because although there might be sort of 5 major lobes in the brain, there's probably about 15 to 18 different neuroanatomical subtypes or sub-regions. And if you look at people who are mapping out the pathways in the brain through studies called connectome studies, they're looking around 220. That's too complicated for us, but we should be looking at different neuroanatomical subtypes in the brain. And if something is in the front of the temporal lobe, it'll act differently to something in the middle of the temporal lobe versus something higher up in the temporal lobe. And we can try to differentiate that in our treatment design as well. So we gather all that information through a number of imaging sequences and try to work out where these sort of tumours are extending. So you can see in this example here, the tumour isn't just one lump, it's traversing a pathway through the brain. Whereas this one here is more an established lump in one area. So every case needs to be individualised in that way. The next phase is using the software to convert that sort of drawing or that sort of target volume creation that we make and putting it into our systems so they can be then delivered. And this is where a lot of changes have really made and really been able to allow us to treat more of the tumour to a higher dose and minimise the dose to the good cells. This is an example of how we design the radiotherapy in the target volume delineation. And we're not treating things in circles, so we can treat things which are being pushed, the dose can be pushed in certain areas. So these are almost a bit like weather maps. So when you're looking at a tumour in this area here, and there's also extension of the tumour to that region there, we want to put a very big heavy storm there in red and have lighter rain in the surrounding areas and no rain in important areas such as the temporal lobe on the other side. So we can swing dose around these areas, and we can also give higher doses to certain areas and lower doses to other areas, which in the past, going back 15 years ago, we actually didn't like doing at all. We wanted everything to be very even. So we can change the way we're delivering it through the improvements in software. And now for most departments coming through, this is an example of what used to be done. That looks a bit embarrassing. That's what I did back in 1996 when I started as a specialist. Rather than designing it on the CT scan, we just did a plain X-ray. Then we moved to improved techniques, which we were proud of, and this is what I used to do back about 2001, where we were able to do the work on a CT scan and map everything out and create these nice colour maps, but we put a lot of bad dose in the surrounding brain and everything was still very rectangular or rectangular prism in shape, not conforming to the way these tumours move through the brain. But now we can do a lot of stuff with software. And it's amazing how quickly it is, because now we just tell the robot to do it. So we can actually put the parameters in, what dose we want to get to a good area of the brain, what dose we want to get to the tumour, and then we design the treatments appropriately. And in fact, like, this is a good example because this was produced by our department within about 25 to 30 minutes. And I actually sent it back because they left Tasmania off. So we actually had to put Tasmania in. And we were still able to get a dose between Tasmania and the mainland and spare Bass Strait to a certain level. So we can do things now, but we need to know where the tumours are. So the important person in the room now becomes the neuroradiologist as well, and getting the good scans and translating those into our treatments. And that pathway is now opened up, and the quality of the MRI scans is improving. And even in the federal budget in the last couple of days, there's been a lot more funding towards MRI scans because the government realises that it's an important aspect for overall care of not only our patients in these illnesses, but also other illnesses. So then comes to treatment delivery, and a lot of people concentrate on those machines. So a basic machine is what we call a linear accelerator, and this is a standard New South Wales Health linear accelerator. If there's a little bit of money left around after the cancer centres get built, you get a nice roof, which makes things, but it's purely no function at all apart from making you feel relaxed for the 7 to 10 minutes you're in the room. But most importantly, these machines, the beams coming out of there, but every machine now has got a CT scanner on the bed. So each day, the therapist can precisely localise. The mask is there to keep you still, not to aid in the localisation. So we make a mask of the face to keep you still on the bed and draw all over the mask. All the localisation is done on imaging performed before you get the treatment delivery. And that's what we call image-guided radiation therapy. And that's been a huge breakthrough because we now can target areas with a much smaller margin for error. And then we can be much more accurate. And we can also look at the tumour in the middle of the treatment. It's a poor quality CT scan, but it gives you some idea of how much swelling there is occurring and whether we need to change things. Gamma knife is something which is raised quite often. There is a gamma knife unit in Sydney, and the gamma knife really has its purpose not for our primary brain tumours, but for metastatic lesions. But all of our linear accelerators can do the same thing that a gamma knife unit can do in terms of treatment delivery to a very small target. So most of the targets that you're treating with stereotactic radiotherapy or with gamma knife, it's a different condition to what you're treating with primary brain tumours. And usually the targets are in the order of about 15 to 20 millimetres. And the aim is to give a very high dose. So rather than over 6 weeks, you really put a high dose just into one area. There's been ways that it's been utilised in the past for gliomas. Michael Barton, whose name was mentioned here beforehand, did some really pioneering work at Westmead and Liverpool to try to establish that. But most of the studies now show there's not a large role for boosting tumours after treatment with a stereotactic radiosurgery approach. But gamma knife has got a very important role, as with linear accelerators, in stereotactic radiosurgery for our patients with metastatic brain tumours. This is the interesting things that are coming through. This is a proton machine, and the proton machine is due to be in Adelaide in 2025, 26. It's a moving target at the moment. It sounds great, but what's happened in the past is that a lot of the benefits of protons, which is the same, is broadly the same effective radiotherapy in the brain tumour, they're being duplicated by our linear accelerator machines and the software we've got. So the benefit of protons is not to give any different type of radiation dose, it's just to try to get the dose off the surrounding brain a bit more accurately. This is our current treatment. It's probably a poor example of current treatment, but this is the proton beam. So this part of the dose here, or this part of the brain here, is not getting as much rain in that rain cloud analogy, whereas in our current treatments we do splash dose across the surrounding brain. But what we do when we're designing our current treatments, we steer that dose away from it. The protons may have this advantage through a couple of biological improvements, but there's also a lot of uncertainty about the dose in this area here, and we have to be careful about that. It also puts a lot more dose through the skin as you're coming through, so you're more likely to get some permanent hair loss if the treatment's not designed in certain ways. So It has some potential benefits for certain types of tumours, especially in the paediatric sphere, but may not have a lot of role in our patients with primary brain tumours, and there's no role as such established as yet. But there will be potential patients who might be considered for treatment with proton therapy in Adelaide when it opens. But once again, there's an emphasis on not so much what the machine does, but you've really got to work out where you're delivering the dose to, and that comes down to not the machine, but the people who are designing the treatment. And that's what's important. Within a radiation therapy unit, you might see me, but behind me are all these other people who are involved in design of the treatment, calculation of the dose, making sure things are accurately delivered, making sure the dose is there. So you need a lot of smart humans in the background for the treatment to be delivered. The final aspect I want to emphasise is follow-up. And this is one of the most important parts of that radiotherapy pathway, and in all your care pathways, be it if you're managed with surgery alone, or be it if you're managed with a radiotherapy avoidance protocol where we're not treating you with radiotherapy. So follow-up becomes an important aspect in looking at, especially of how we interpret the imaging. And a radiation oncologist has got a lot of role in this regard because we know where we've put the dose and we know where we might have post-treatment effects on the surrounding brain that makes your subsequent scans more difficult to interpret. So here's a good example. A patient presents with a scan which shows quite a large area of change after treatment. A concerning feature, it looks like a recurrent tumour, but it's right where the high dose was that the radiation oncologist delivered. So that is more likely, based upon the shape, where the rain cloud was most stormiest, is more likely to be something related to a radiotherapy treatment effect. It still needs to be followed closely, so it's not a diagnosis in itself, but treatment effect is something we have to be very considered in looking at in the months after a course of radiotherapy. Likewise, we get this condition called pseudoprogression early on as well, where a patient has changes in the surrounding brain, around the cavity area, and then they get a lot worse. And then without treatment, it just comes down. So here it's called tumour. It can be very confusing, but then it settles down. We look very closely not only at what the scan looks like in terms of how much light's up, but the shape of the area as well. So if an area is maintaining its same shape, it's less likely to be recurrent tumour. So this is a patient who had a nasty treatment effect. They've then had a drug called Avastin, which reduces the swelling down, and they're left with this abnormality here. But the initial abnormality and the subsequent abnormality look exactly the same shape. So you're considering that this is more likely to be a treatment effect rather than tumour recurrence. But the most important part of it all is looking at the sequence of the MRIs over time and watching to see the changes over time. So in terms of the pathways of treatment, the sort of decision-making going through to treatment delivery, I'll get back on that. A lot of the care that we need to take with our patients is looking at the way we design the treatment, but also how we interpret the changes on scans afterwards. And they can be frustrating, and sometimes you need repeat scans being performed 6 or 8 weeks later to really make that interpretation. I'm not sure people in the audience have had experience with brain metastases, so I'll just raise that, given this is a Brain Tumour Association talk as well. Brain metastases also have a lot of important role in the same pathways. Radiation oncologists need to be wary of the imaging characteristics and then be able to design the treatment to minimise the dose to good brain. So historically, for our patients with brain tumours from other sites of the body, brain metastases spread to the brain, we used to give a treatment called whole brain radiation therapy. But what that involved would be treating the whole of the brain for little lesions which are about 2 centimetres or less. Now we've gone to more focal treatments because the whole brain radiation therapy was involved with potential scar tissue in the brain. And our software has improved that we can now target these tumours very carefully, giving a high dose to certain regions and sparing the good brain. And sometimes you do treatments over a period of 2 to 6 months, where you treat some lesions, see the response, and then you come back and treat more. And we work very closely with our medical oncologists to work out which patients could potentially be watched, what drugs might be able to get to the brain to control the lesions. So we still have a significant role in the management of brain metastases as well. So that's the treatment pathway. That's what a radiation oncologist does. I guess we emphasise now we actually really have to take a greater role in the imaging and understanding the imaging, and also take a greater role in caring for our patients after treatment. But I guess the key thing, similar to what Jacob has mentioned, everything has to be individualised. You've got pathways which you could go in certain ways, and one size doesn't necessarily fit all. And as Jacob mentioned, you also have to ask questions. So ask what's being done. Thank you.
Thanks, Michael. That's such an elegant talk. There's so much maths and physics involved with radiation oncology, and that was a beautifully accessible talk. So thanks again, Michael.